I am Dr. Saqib and today we will discuss the anatomy of the scalp. So, scalp, you can define it as consisting of the skin, which normally is hair bearing, and the subcutaneous tissue, which covers the neurocranium. So, extent is here from this supraorbital margin on the frontal bone. This is the frontal bone, and this is the supraorbital margin, and the scalp extends from here going backwards to posteriorly to this occipital bone point. This is the our superior knuckle line. So extent is from supraorbital margin of the frontal bone to the superior knuckle line on the occipital bone. And on this side, laterally below, this is the blending of the scalp with the temporal fascia over here, which extends up to the zygomatic arches. This is the zygomatic arch. So this is the extent of the scalp from this to this. This is the scalp. So layers, there's the 5 layers. The first 3 of which are the scalp proper, which are very closely intimately related with each other and move as a unit. So this is the scalp proper, first 3 layers and the total of 5 layers. So you see, this is the word scalp, S-C-A-L-P, and each of its word, S-C-A-L-P, this serves as a keyword for all these 5 layers of the scalp. Yes, you see, this is the S and this is the skin. Yeah, this is the C, this is the connective tissue. This is A, and this is the aponeurosis. This is L of the scalp. This is the loose connective tissue. And this is the pericranium. So this is the 5 layers coming from this keyword scalp. Each letter giving rise to these 5 layers. You see all these 5 layers here. This is the skin, outermost covering, with of course hair, mostly in the hair follicles, sebaceous glands related with that, and also the sweat glands. Below that is the dense connective tissue. Below that, third layer is this aponeurosis. This is also known as Galea aponeurotica. Galea aponeurotica. This is important because the muscles of the scalp, which is the Occipitofrontalis, the digastric muscle consisting of the 2 bellies, I'll show you very soon. So they are attached with this layer, aponeurosis. So this is a strong layer band, strong band, like a tendon. So this is a aponeurotic, epicranial aponeurosis, or the Galea aponeurotica. Very densely. These 3 layers are very strongly attached with each other and are known as the scalp proper. So below that is a loose connective tissue, which has a lot of potential spaces, and it is responsible for the collection of pus in that. Below that, this is the pericranium, which is firmly adherent to this neurocranium, this pericranium. So this can be easily stripped off in the living person from that neurocranium, except at the sutures where it is very firmly attached. So these are the 5 layers of the scalp. So this way, here that this is the occipitofrontalis muscle, digastric muscle. Occipitofrontalis has 2 bellies, frontal belly, and this is the occipital belly. You see the occipital belly first. You see, this is the superior knuckle line, the back side of the skull. So the lateral 2/3 of the superior knuckle line gives origin to the occipital belly of the occipitofrontalis, and this gets inserted into epicranial aponeurosis. And this is the frontal belly of the occipitofrontalis, and it is taking origin from this epicranial aponeurosis, and it is inserted into the skin over this region, for the frontal region and this eyebrows. These are the attachment. So their actions of these muscle is this frontal belly, when it acts independently, it protracts this region, scalp, anteriorly protracts, and then produces wrinkles, transverse wrinkles onto the scalp. These are the transverse wrinkles, pulls the eyebrows upwards. So, right, this is an action of the frontal belly of the occipitofrontalis. And this is the occipital belly. What it does when it acts independently, it redirects the scalp, to takes it posteriorly. But what happens that these two muscles are synergists and they act in synergism. So acting synergistically, these two muscles produce this muscle condition, which is this transverse furrows over here, elevation of the eyebrows, and this is a combined action of the occipitofrontalis. And there, this is an expression produced as surprise. This is the surprise. This is a surprised look produced by occipitofrontalis. There are muscles of facial expression whose contraction of each and every one produces a typical facial expression. So the expression produced by occipitofrontalis is the surprise. So this is the occipitofrontalis present in the third layer, and this is the muscle of the scalp and its various dispositions. This is even tabulated over here, right? So this is action, and this is the complete description of the muscle. So going on, and this is and mention that this is the occipitofrontalis is supplied by facial nerves, like all of the muscles of the facial expression. Of course, they develop in the second pharyngeal arch. It's mesoderm, so its nerve is a facial nerve. So now the nerve supplies very richly, nerve supplied, and this very sensitive structure, the scalp, and it is divided into two parts for studying. This is the auricle, and one part anterior to that, and the other part posterior to that auricle. Anterior to auricle and posterior to auricle. The four sensory nerves anterior, four sensory nerves posterior to the auricle. So what lies anterior to the auricle? All nerves come from cranial nerve 5. That is the trigeminal nerve, which has three parts. One, which is the ophthalmic division, and two, which is the maxillary division, and three, which is the mandibular division. Ophthalmic, mandibular, and maxillary, right? So this is what comes from this ophthalmic division is a supratrochlear and supraorbital nerves, just supplying this area. And zygomaticotemporal nerve coming from this maxillary portion of the trigeminal nerve, supplying this area, and it is mandibular branch, which is a auriculotemporal nerve. So these all branches of our trigeminal nerve supplying this, four branches supplying this area of the scalp anterior to the auricle, and posterior to the auricle, again the four branches coming from the spinal segment C2 to C3, and these two branches are the anterior MI branches coming from the cervical plexus. These two are branches of the cervical plexus, which are what? Greater auricular nerve and the lesser occipital nerve, right? So posterior to the auricle, greater auricular nerve, and lesser occipital nerve coming from the cervical plexus. Going backwards, again two nerves which come from dorsal rami of the spinal nerve, C2 and C3 here. C2 gives the greater occipital nerve, and the C3 gives the third occipital nerve. So these are the sensory nerves of the scalp. And also you see in this picture these sensory nerves. This is the anterior view, this is the lateral view. This is just for academic interest. This is the supratrochlear and supraorbital branch, right? This is coming from the trigeminal nerve. Its first part is the ophthalmic nerve. That is this zygomaticotemporal, and this is coming from its this second part, which is of course this maxillary vein, and then the mandibular vein, which is the auricular temporal nerve. And you can see also laterally these branches: supraorbital, supratrochlear, zygomaticotemporal, and this auricular temporal. Right? This is it. So these are the four branches coming from the trigeminal nerve, supplying the scalp. This is two branches which supply the motor nerve supply of the scalp, of course, to the epicranial epineuritis parts, occipitofrontalis. This is the frontal belly of the occipitofrontalis, and this is the occipital belly of the occipitofrontalis. The two branches concerned over here, branches of the facial nerve. This is the temporal branch, supplying the frontal belly of the occipitofrontalis, and this is the posterior auricular branch, which also supplies this part. This is the occipital belly of the occipitofrontalis. So two branches of the facial nerve serving as motor nerves of the scalp: temporal branch and the posterior auricular branch. Then to the arterial supply of the scalp, very, very rich nerve supply, very rich anastomosis, which is anastomosing on each other, the same side and also with the opposite side. So rich anastomosis. So that is why when there is a laceration and there is a cut over here, these vessels profusely bleed. And another reason for profuse bleeding is that these arteries are embedded deeply in the connective tissue and attached with it, so they cannot contract when there is bleeding. They're cut, so they remain open, and they are bleeding profusely. So what is the names of these arteries supplying over here? They are coming from the external carotid and the internal carotid. This is external carotid and internal carotid. You know, these are branches of the common carotid artery: external carotid and internal carotid arteries. And these two branches bearing this asterisk, they supratrochlear artery and the supraorbital artery, they come from the internal carotid artery. You see this. This is internal carotid artery. It gives over here this supraorbital and supratrochlear. They come from the supratrochlear and supraorbital. They come from this internal carotid artery. And rest of these three, superficial temporal, posterior auricular, and occipital, they come from this external carotid artery. You could see and identify all of these. This is the occipital artery, this is the superficial temporal artery, and third is the posterior auricular artery. This posterior auricular is all stem from external carotid artery. You see, this is the posterior auricular, this is the occipital, posterior auricular, this is the superficial temporal artery. Of course, superficial temporal is the terminal branch of this external carotid, one of the terminal branch. Other is this maxillary, this transverse facial. So these are the branches of the supplying the scalp. This is the superior view. You can see, as you see note the anastomosis. So that is why even here we can discuss the applied aspect. So whenever these cut deeply, they need to be stitched very immediately to stop the bleeding. I told you, because the arteries cannot contract as they are very much embedded into the dense connective tissue, and they cannot contract on their own, their walls. And you see, this is the venous drainage of the scalp. This is a little bit tricky and difficult. I will revise it with you even when we study face. And over here you see some branches like this is the superficial temporal vein, this is the supraorbital vein, this is the supratrochlear vein, right? You focus on that. Then this maxillary vein, and then posterior auricular vein, then this retromandibular vein. So these are all veins, right? So what happens here at the scalp? You know, there are the branches of arteries like supraorbital and supratrochlear. The arteries and the veins are the same name, supratrochlear vein then, and the supraorbital vein then, and then the superficial temporal and posterior auricular and occipital vein. So let's see one by one. Supraorbital and supratrochlear. What is happening over here? These two veins unite here at this angle of the eye orbit, and they form the angular vein. Supraorbital vein and the supratrochlear vein, they form the angular vein, which descends downwards and continues as this facial vein. Angular vein continues as the facial vein. One end. And what is happening on the back side and the laterally, and this, you see, this is the superficial temporal vein. You see over here what happens. It comes downwards here, going anteriorly and downwards, right? This is the way it goes, right? And this is the our posterior auricular vein over here. You see this, and this is various formations. And this is the formation of the retromandibular vein. Retromandibular vein, which has an anterior and posterior vein. What is this detail and how they go into the brachiocephalic vein or internal jugular vein? And that I will discuss with you in the next venous drainage of this whole region as a topic. So in the scalp, you just see that this is a superficial temporal vein, supraorbital vein, supratrochlear vein, and again this posterior auricular vein. Arteries, these veins are with the arteries the same name. The supratrochlear vein, supraorbital vein, then superficial temporal, posterior auricular, and then also the occipital vein. You just remember they drain this area for the venous drainage. So then is this lymphatic drainage. We'll keep it simple. There is no lymph node present in the scalp, and in the area above this scalp, this area anterior to the this auricle, this is draining into the this parotid area. This is the pre-auricular lymph nodes. So area of this scalp, which is anterior to this auricle, is draining into lymphatic drainage. This is into this pre-auricular lymph nodes, and the area behind that drains into this mastoid and the occipital lymph nodes. These are the lymphatic drainage, post-auricular and this mastoid and the occipital. Again, the lymphatic drainage is also very profuse. Then some applied aspects which some already discussed with you, that the superficial scalp wounds do not gape. So why? Because below the above two layers, which is the skin and the connective tissue, is the aponeurotic layer, which is very strong. So it does not allow any blood to go inside, and neither it does not allow the wounds to gape. But if there is a coronal laceration, because if there is a coronal laceration of the aponeurosis, the epicoronal aponeurosis is lacerated in the coronal plane, what happens? The frontal and the occipital bellies of the occipitofrontalis are separated, so they move in the opposite directions. Like the frontal belly will like protract this area, and the occipital belly will retract, and this will gape. The wounds will be wide open. So this is needs immediate deep stitches. So let's see what is the danger area of the scalp. Of course, this is the layer 4, loose connective tissue, which has the potential spaces for the collection of the pus or blood. And also there are emissary veins which take the infection to even meninges. And then why the scalp infection enter the eyelids and the root of the nose? Because there is a frontalis muscle of the facial expression related with the nose, It also has no bony attachment and inserts into the skin and the subcutaneous tissue. So the skin of the eyelid is the thinnest of the body and is delicate and sensitive. So because of the loose nature of the subcutaneous tissue within the eyelids, even a relatively slight injury or inflammation may result in an accumulation of fluid. So that causes the eyelids to swell. So this leads to black eye or the periorbital ecchymosis. Black eye, what is that? So if there is any blow to the periorbital region, so it produces soft tissue damage and the tissues are crushed against a strong and relatively short margin. So this is the black eye produced. And this is also a point to be noted that the frontal belly of the Occipitofrontalis also has no bony attachment. You see, this is black eye ecchymosis, periorbital ecchymosis. This is the black eye typical appearance. This is due to the danger area of the scalp. This is the loose connective tissue. Blood easily trickles down into this area. What are the sebaceous cysts? You see, this is a sebaceous cyst rather in the scalp. And why does it is produced? Because the ducts of the sebaceous gland that are associated with hair follicles in the scalp, they become obstructed and result in retention of the secretions and formation of the sebaceous cysts. It's also known as vents. These sebaceous cysts are known as vents. This is a term used for them. It's because they are in the skin, sebaceous cysts move with the scalp. What is a cephalohematoma? You see, this is the cephalohematoma. What is that? Like you see, if a child is being delivered and there is a spontaneous vaginal delivery, so there can be an injury in the local, and what happens here? There's a blood collection. In which area you see this? These are the 5 layers above. This is the last layer, and this is a periosteum, and this is a bony neurocranium layer, and the blood collects between these 2 layers. This is forms cephalohematoma. Usually it occurs at the parietal region. Right, you see, this is the periosteum, and below that this bleeding occurs, and this is the bone, which would be of course neurocranium, parietal bone. So between these two, there is collection of the blood, cephalohematoma. It is a benign condition. It usually resolves itself. So pulses can be taken the scalp. Pulse is for the superficial temporal artery, where it crosses the zygomatic process just anterior to the auricle. Zygomatic process just anterior to the auricle. An anesthetist can use that. And this is the last scalp laceration. I told you already, very common type of head injury. So because there are present abundant anastomosis, so if there is laceration produced, so it needs immediate suturing. Otherwise, blood would be lost and that will create problems. So here we stop the discussion on scalp, its anatomy. It was a slight sort of definition, then the discussion about the layers of the scalp, the 5 layers, and its nerve supply, very important, its arterial supply, the venous drainage, the lymphatic drainage, and some very important applied aspects like this, especially black eye. And with this, I stop. And inshallah, we'll come very soon in the next lecture, very soon, inshallah. Thank you very much for listening.